Good morning, everyone. It's wonderful to see all of you and wonderful to have this fantastic panel following that great conversation with Mike and Mandy Cohen, the director of the CDC. I want to begin the panel by actually reminding us of some of the data and statistics that Mike went over in the earlier session. So I will begin with information that we're all quite aware of, which is the challenges that we're facing in the US healthcare system. I think all of us know that, unfortunately, with the level of spend that we have here in the US, a fifth of the US economy, about 20% of GDP, is spent on health. However, our outcomes are not matching up. If you look across the world as well with the demographic shifts, what you notice is that as a society, we're having less children. Other parts of the world certainly are not following this trend, but we are in Western hemisphere and also in Asia. And people are living longer. And what does that translate into, right? You see this shift across the economies. These are usually high-income economies that we have. The declining birth rates, and yet, as we see in sub-Saharan Africa and other parts of the world, those birth rates are increasing at a significant pace. We also see the aging demographic and populations. What we expect is that life expectancy is going to rise, and which is a good thing, but it's not necessarily leading to better health, right, in those later years. And how do we address these kinds of challenges and issues? Chronic diseases are on the rise, and these chronic diseases are a result of a number of factors, right? It's a result of our lifestyle, food, nutrition, and health, access to medical services, or in some cases, lack of access to medical services. We talked about this in the last session, and Mandy pointed to this data. We still, across the world, have, unfortunately, bad outcomes from cardiovascular disease conditions, cancer, and I know we'll talk about that on the panel, and the list continues to go on. So disease burden is rising. We need to think about new sets of solutions. So is innovation the answer? I think you'll hear from this panel, they will say yes. Innovation is absolutely part of the equation. It's part of the answer. I would say innovation is as impactful as getting it to people. So we need to do innovation on both sides. We need to have innovation implementation, and we also need to have innovation in the development of new vaccines, new therapeutics, leveraging diagnostics and devices as well. What you also see here is the potential for innovation to address issues like health equity. I think for many conversations, certainly those that I've been a part of or leading, it's really about the challenge of health equity. I think we need to turn the conversation upside down and think about the promise of innovation and technology and really leapfrogging and addressing the needs in low-income and underserved communities. You cannot get through any conversation, and certainly throughout the conference today, and in the next coming days, you hear about AI and how it's being applied and used, the promise of AI to transform medicine. We'll talk about that on this panel as well. We certainly see improvements that are happening in clinical workflows and note-taking, for example. But how does that translate to the patient? Where is the efficiency? And then, of course, how do we have the appropriate guardrails in place as well? We can think about AI potentially helping with the issue of workforce. Okay, certainly not AI replacing the workforce, but AI being used as a tool to augment the healthcare workforce and enable especially physicians, and we have a number of them on the panel today, to really give them more time with the patients rather than less time with the patients. Part of that is going to also be around not adding more to the physician workload just because we have some efficiency gains because of AI. So those are the conversations that we're going to have on this panel. And certainly, as we heard from the earlier panel, prevention is such a key part of all of this, right? How do we shift that trajectory in overall healthcare cost? So I want to start first by talking to Meena, Dr. Meena Seshamani, who is the Deputy Administrator at CMS and the Director of Medicare. You lead our nation's healthcare program in charge of seniors, those 65 and up, which is about 65 million Medicare populations. People age into that program. You are at the forefront. You know, when Medicare makes a decision, it's a signal to the rest of the marketplace about the direction that you want to go. So as you looked across the data that I just shared, as you think about this prevention agenda and the shift to value-based care, How is Medicare thinking about leveraging both its purchasing ability and power to address these really multifactorial issues?
Well, thank you, Esther, and it's really wonderful to be here with all of you and to be on this panel. I think we represent kind of the pieces of the puzzle that go into how do we keep people healthy, how do we provide better care, and how do we make sure that the dollars are being spent in the smartest and most effective way to do so. So, as you mentioned with the Medicare program, we care for more than 65 million people. We pay nearly $1 trillion in claims each year. So where Medicare goes, much of the rest of the system follows. And it's important to remember also that the gaps that have occurred, I think as Mandy had mentioned, the gaps that occur in earlier parts of people's lives, guess who experiences it? When they age into Medicare. And then they have accumulated all of those experiences through their lives that impact their health for then it to be addressed. So, I view the Medicare lever really as not only caring for people when they reach our program, but sending that signal that we need to partner even before they reach our program. So you mentioned value-based care. So, value-based care ultimately is how do we care for people as people? When you go into a doctor's office, you are much more than just your ICD-10 code for the disease for which you are being seen that day. And we all know that 80% of our health is determined outside of that office visit. So how do we actually flip the paradigm of how we care for people so that we're actually caring for people and not just treating an individual disease to be more effective? So these holistic care models that we have created are really seeking to do that. So, as a concrete example, I was leading care transformation in a health system before I took this role. We had one woman who came into our ED, one of our EDs, 17 times in 3 months. And for exacerbation of her lung disease, chronic obstructive pulmonary disorder disease, COPD. We assigned a community health worker to her who went to her house and discovered that her electricity kept getting shut off because she wasn't able to pay her electricity bills, so she couldn't use her nebulizer. And that's why she kept coming into the ER and getting admitted to the hospital. So this community health worker was able to work with, the utilities, BGE, and was able to fix that, and guess what? She stopped coming into the hospital. So that is an example of how when you move care upstream, you are able to care for people in a better way that actually then spends the money in a smarter way as well. And oh, by the way, that community health worker was someone who was hired from some of the most disadvantaged zip codes for the catchment area of our hospitals. So it has this ripple effect across the entire economy and society as well. So I can go into all sorts of technical details. We have instituted many policies to try to bring more people in Medicare under these kinds of models. We now have more than half of people in traditional Medicare in one of these arrangements where groups of healthcare providers come together and take accountability for the cost and quality of care. So speaking to some of the leading causes, as you mentioned, of death in this country, cardiovascular disease screening, diabetes screening, cancer screening. Healthcare providers have to meet quality metrics, and then if people stay healthy, they stay out of the hospital, they save Medicare money, they share in the savings with us. So I think that's one key way that we are seeking to move care upstream, to address issues of preventing illness and turning our system from a sick care system to more of a healthcare system. I think the other point that both Mike and Mandy spoke about, and Esther, you highlighted, the innovations are wonderful, but they're only as wonderful as people are able to access them. And to take the example of vaccines, I think as Mandy described, we all know how important trust is and meeting people where they are. So now in the Medicare program, even outside of these holistic care models, we are paying for care navigation. We are paying for community health services. We're paying for caregiver training because as people get older, who is taking care of them for the 23 hours and 50 minutes in the day when they're not in that 10-minute office visit? It's oftentimes a family member, a community member. So enabling healthcare providers to adequately train those caregivers for all of the issues that they are dealing with. And so building that trust, reaching out into the community, and also addressing the financial barriers. So now, because of the Inflation Reduction Act, the drug law that was passed, people in Medicare have access to preventive vaccines at no out-of-pocket cost. The number of stories that I heard from seniors across the country of the shingles vaccine costing them $200 to $300. These are people on fixed incomes. In implementing this $0 vaccines, the number of seniors who have gotten a vaccine has skyrocketed from 3 million to 10 million.
Yeah.
So just being able to enable trust, meet people where they are, and eliminate financial barriers is also key. And making sure that people know about all of this, right? Again, shingles vaccine now costs nothing. I can't expect a 72-year-old grandmother to suddenly wake up one morning and say, oh, I'm going to go to my pharmacy again and check if that price of the shingles vaccine changed today. It is incumbent on all of us that we get the word out to all of our communities about the importance of prevention, about the importance of all of the changes happening, that we do want to care for you as a person. And here are things that you should ask your doctor, ask your nurse, so that we can make sure that the changes that we make in a 2,000-page payment regulation that sits in the Federal Register actually comes to life for people on the ground.
Yeah, Meena, that was fantastic and really stellar to hear about a policy change for out-of-pocket cost driving up utilization. That's exactly what you want to see from a policy perspective. And you really articulated very clearly what value-based care means, which is to go beyond what happens in the four walls of a provider room. And you talked about education, the need for us to get the word out, right? And how do we innovate on the education angle as well? We'll come back to some of those topics. Karen Knudsen, I want to come over to you. You serve as CEO of the American Cancer Society. It's an incredible organization that you took leadership of 3 years ago, and really, I would say, and commend your leadership, because at a time when we saw charitable giving going down, you were able to really pick up and bring that back up at levels above and beyond what happened before you took on that role. Also want to commend you for being the first woman leader of an organization that's 100 years old, so congratulations to you. I know that this topic of prevention, right, for a healthier tomorrow matters a lot to you. It matters a lot to individuals who are living with cancer, who are going to be diagnosed with cancer. When I looked at your data, we expect over 2 million new cases of cancer diagnosis this year, right, in 2024. So there's certainly a lot more for us to do across a number of topics, including what Meena just talked about. Why don't you just outline for us what your priority areas are relative to where you see this burden of disease?
Yeah, thank you so much for that. You know, I'm a reformed healthcare executive, came to ACS from the healthcare system, leading oncology for a large health system across 2 states. And what I remind my team all the time is we won't fix healthcare. I do believe that value-based care is the future. But until that time, what can we do with our key stakeholders, patients and their caregivers, their families, to improve lives? And so here's really where I think we are to lay the framework for cancer. You know, cancer is not diabetes or heart disease. It's 200 different diseases that all arise due to a different reason and require different treatment and prevention strategies. If we look at them in total, there are some which we're really making significant gains, some for which we have stubbornly not been able to improve, and others that are truly going sideways. So our priorities are set by that, those data on trends for incidence and mortality that we track and report to the nation every year. It's actually the most highly cited publication in all of science, not just all of oncology, is our cancer report every year. So that's how we set priorities, and set priorities by zip code, which you saw earlier today is so important. So when we think about prevention for cancer, we know that only about 42% of cancers are attributed to modifiable risk factors. So that's an important number. We want to educate people about what to do to engage in preventative strategies for those 42%. But that leaves a vast majority for which we have no preventative strategy. So for cancer, it's a little different. We need to bundle prevention with early detection. Right now, for mid and large size employers that are self-insured, cancer is the #1 cost of care. So this is absolutely, crippling to a large number of different organizations across the country, but also to the families and individuals that are affected. We know that if you just take all of those 200 cancers and you bundle them, that the difference in cost between a stage 1, so localized disease, and stage 4 diagnosis is 75%. So important to catch those cancers early from a cost perspective, but most importantly, from an impact perspective on people. 6 to 8 times more likely to survive your cancer if detected early. We only have a subset of cancers for which we have a screening strategy. I think innovation is going to see that change. But, Esther, to your question about what are our priorities, we must continue to innovate. The innovation has to be across the cancer continuum, prevention, early detection to management. But the other 2 parts of ACS are dedicated to getting those innovations to people through policy at the federal and the state level. We do a lot, with elected officials. I'm really glad to even, talk to some of them today and yesterday. The great governor of Hawaii is sitting right in the front, where I think we're already planning some things to try to work together. But also patient support. You talked about working with and in communities. We have a presence in 5,000 communities across the country to solve for the things that truly make a difference. Education, patient navigation, transportation, lodging. These are the things people often don't think about when they think about outcomes for cancer. And when I was running oncology for Jefferson Health, 16% of our patients on any given year could not complete care as planned because they had no ride. So it's as simple as if my friend Dave can get to the chemotherapy center 5 days a week and I can only get there 3, who's going to have a better outcome? So there's the biology, and we have to continue to push and innovate, and we have a lot of levers for that, but we have to get those innovations to people.
Yeah, absolutely. And when we think about where we are from a screening technology perspective, it's actually quite exciting to see, right, the number of potential innovations that really are at our doorstep that are going to allow individuals to get screened, the blood biopsies, leveraging other samples, urine, et cetera, to detect for cancer. Anecdotally, I've had conversations with people to talk about these tests, these multi-cancer early detection tests. And the answer was, I thought I was doing that already when I went into my physician's office for my annual visit. So there's a bit of education that needs to happen with what happens in that annual visit and what's the potential for this new technology. So thank you for prioritizing that. I want to come over to you, David Feinberg, who serves as chairman of Oracle Health and many, many other titles that you've had over the years, leading large health systems, Geisinger, UCLA, Google Health as well, and to bring in your perspective from a technology perspective, because what you've talked about, David, is that your fight is against disease, right? And I just went through that list. How do we do better by cardiovascular disease? How do we do better by cancer? One of our challenges in the US is just the fragmentation of the data silos that we have, right? The lack of ability to move our data individually, to move our data across health systems, to have a holistic view of an individual, what happened when you're early in life versus later in life, with all of the periodic episodes of care, et cetera. And so why don't you just tell us about how you're thinking about overcoming these solutions at massive scale. Where are we in this pivot? Because we've been anticipating this for quite a bit of time. We're getting more and more. Mickey Tripathi is here as well in the audience, who leads ONC, the Office of the National Coordinator for Health IT, leading this effort. But certainly you have, from a global perspective, such an incredible role as a leader transforming this industry. We'd just love to get your perspective.
Well, it's super great to be with this group and to actually hear Mandy before, and I'm looking forward to Bob, and these comments are great. And you're an amazing moderator, Esther. I just keep thinking, I think Esther should be on The View, but that's We're gonna
With
do
all
that.
of us.
Well, with us, yeah. I'm just like,
take the show on the road.
In my brain, I'm thinking like, come up with an answer, but I'm just listening to Esther. Anyways, so I think I've had this opportunity to see healthcare from a lot of angles. I'm a child psychiatrist trained here at UCLA, and I describe my current job as my second best job I've ever had. The first being taking care of kids with autism and ADHD. But let me get to why I think this is the best job for me right now. I think now is the time. Like, so many things, some good, some bad, have happened that are going to allow us, I think, to make incremental changes for seniors, for those with cancer, drug discovery, public health worldwide. So a few things. It took us, I apologize, 40 years to digitize the record. But we got it digital so that no one during COVID went into the ER and they said, I'm sorry, we don't have your chart. Dr. Smith took it home over the weekend. Now, I've lived that before. And no one during COVID said, the pharmacist said, is this amiodarone or amiloride? I can't read the prescription, right? So we fixed legibility and access to records. And we say they're interoperable. Well, that's not really true. But anyways, we have fixed the digitization of it. So what's next? The other piece that I think is really important in this is COVID gave the world a public health 101 class. So during COVID, I was at Google. We had 50 billion, I think it's now 80 billion, 50 billion impressions of our COVID information page on YouTube. So the whole world learned vaccine, bend the curve. I mean, it was just all of a sudden public health became the, we probably had close to 18 billion searches a day just on healthcare. So pretty amazing from scale. So digitize the record, the world learned public health, and the other piece in that I think is really important, I think those of us in healthcare, shame on us, have known this for a long time, there's huge inequities in care, right? And that came out during COVID, and it's with Mike's slides of, you know, you right here, if we went 10 miles south, you get that same 20-year difference in life expectancy if you went down to Compton or whatever. So those things are coming together, and then there's this new technology. And I would say the most important of all the new technologies is not AI, it's cloud. And the reason cloud is so important is it increases security. And Meena talked about it. I always say healthcare is people caring for people, and it's built on trust. We happen to be the biggest EHR company in the world. We'll be the biggest in the US when we're done with our VA rollout. And I translate to that to the team is that means we have more of grandma's blood sugar than anyone else. Well, we better keep it safe. We better then understand upstream what to do with it. So, okay, so we have this confluence of the world knows public health way more than they did. People are focused on inequities. We've digitized the record. The cloud allows us to keep it safe and secure. So now what can we do? So we're trying to do two things. And the first is fix the EHR. So if you're a doc or a nurse, these things were never designed for you. They were designed for labs and billing. There isn't one industry in the world where the users actually work on the system of record. When you folks go to Expedia, you actually don't know what system of record is underneath. Your work, or you may pick some other app for travel. We've made doctors and nurses and social workers and occupational therapists actually work on that system of record. It's impossible. So we've launched a product we call Oracle Digital Clinical Assistant, but so have the other EHRs. And it goes like this, like, hey, Oracle, tell me about my next patient. It summarizes it, multiple EHRs, EHR agnostic, brings in social determinants of health. The person has given me the permission to use the phone during the visit. I put the phone down. How's your pneumonia? You know what? I want to check hemoglobin A1Cs. Hey, Oracle, what's the hemoglobin A1Cs? Okay, let's increase the metformin. The pneumonia gets better. I want to get you in a food prescription program. I want to get you followed up in a couple months. Da-da-da-da-da. We're done with the conversation, and all the actions are taken. So I saw a complex outpatient visit with a patient, and I never, ever touched the computer. Like, we've launched it, and here are the emails I get from doctors. Oh my God, I had lunch 3 times this week. I've never had lunch in 6 years. So Okay, great. Fix the usability. That's fantastic. But that's really just that, to Meena's point, that 10% or 20% of healthcare. So we've got to bring in disparate records from multiple parts of healthcare that include back office, like human capital management. If a nurse has never given this chemo before, or has been certified in it but has never actually done it, we should know from human capital management and bring that into the EHR. When I'm done in the operating room, not only should my note get done for me, it should actually drive supply chain so we have predictions of what's coming next. But it's, again, beyond health provider. It's also clinical discovery. So when you think about clinical discovery, the problem is very few people participate in trials. They're really, really focused on academics instead of kind of rural America, or in this case, rural America and the underserved. So Oracle has had history in software to the pharma and device companies. But the other thing that we have, what we call is this Learning Health Network, it's over 100 million records in the United States. It has 3 times the diversity of any of the big national trials. So places like San Joaquin Hospital, which is in the middle of here in San Francisco, it's not like LA or San Francisco. Osmond, Nebraska, population of 800. These places are research naive and are participating in multi-omics around cancer studies. So it's infrastructure to bring the right people into trials, and then from commercialization to make sure those folks are comfortable using it. And we can tell the same story when we go to claims processing. So Oracle processes 80% of the world's credit cards. What is a credit card processing? It's an agreement between a bank and a merchant that agree on the contract and say, okay, this isn't fraud, pay the bill. Well, in healthcare, we get a little messed up and we send these things called EOBs out. And people have asked me, what's my dream? I want to kill EOBs. So
Explanation of benefits?
yes,
Okay.
yes. So I say I have an MBA, I'm a doctor, I've run multiple health systems, I've run insurance companies, I get an EOB from where I went, and I say to my wife, do you understand what this is? So could you imagine if you have lower health literacy? Like, it's impossible. But we have the opportunity to do it. If we can finish the doctor's note before you leave the office, and we can agree with the payers and the providers that are both spending a lot of money fighting, that 99% of the time there is no fight. Imagine you went to the doctor and when you left, you got something that said, hey, you're done with your visit, you want to use your HSA or Venmo, you owe $14. And you could focus on your cancer, not on the cost and the bankruptcy and all those other issues that happen. So to me, it's this opportunity to build a cloud-connected, open, with partners, end-to-end healthcare platform that happens to exist in every other industry except healthcare. So when you talk about retail, banking, finance, travel, energy, entertainment, they do have data flowing back and forth. And it's open and connected, and it's not one player, but nobody has ever pulled it together for healthcare, so that's what we're trying to do.
Yeah, what a vision that you've outlined there, David. And as I think about, all of the different component pieces that you talked about, each of them are about how do you overcome friction, and how do you create efficiency, and how do you improve the user experience. There is no other industry outside of healthcare where we are complacent with bad user experience. And you're saying, no, we need to think about this differently. We need to think about it differently from a provider perspective, the data flow perspective, and ultimately that impacts what the patients experience when they're sitting in front of their provider. So thank you for that. I want to bring you into the conversation, Bob, because you've been listening in both to the earlier conversation and to this one as well. So Bob Bradway serves as CEO and chairman of Amgen. I think identified as one of the best places to work, which is a great accolade. When you're thinking of the innovation pipeline, the whole focus and the reason why your employees are so happy to be there is that they want to wake up every single day thinking about how to make the world a better place and how to make people healthier, right? So you're working upstream, thinking about new molecules, how do you identify best-in-class medicines, how do you develop them as quickly as possible, leveraging technology, how do we get them to the patients that can benefit the most? But then you experience every part of the friction of the system that we just talked about. the friction of access, the friction of all of the navigation that needs to happen across different disease conditions, the friction of technology. So why don't you just walk us through both what your priorities are from an innovation perspective, but how do we innovate on all these friction points so that we can actually experience the benefits of the innovation?
Well, thank you, Esther. You're right that the staff of Amgen wake up every day hoping to make a difference for patients suffering from serious disease. That's our focus. We seek to advance medicines that make a big difference for patients that are struggling with tough diseases for which there aren't good alternatives. And that's what animates everything we do in the organization. But there's nothing more frustrating than having an innovation that successfully reduces the risk or even cures a serious disease, and then discovering that that therapy doesn't get to the patients who can benefit from it most. So we spend a lot of time at the intersection points where the friction exists in the system, trying to work through what it is that's preventing people from getting the therapies that they need. And I think David outlined, one of the things that we're excited about as well, which is the opportunity to leverage the intersection of digital information and use that to ensure we're getting the right health care at the right place for the right patients. And we talk a lot about, especially in an aging society, like ours, we think we need more innovation, not less. The data that you shared earlier, I think, make that clear. There's still far too many people dying of heart disease in this country. In fact, every 30 seconds, someone has a serious heart disease episode here in this country, despite the fact that we have very effective therapies to prevent those, despite the fact that there are very few areas of disease where the relationship between your risk of having an event and your having an event is as clear as it is in heart disease. So we spent a lot of time talking about the need for more innovation, and then the need to move away from a system which rewards the fixing of those things that are broken, and instead towards a system that rewards predicting and preventing. The data enable us to predict, the therapies enable us to prevent, and that's where we need to be pushing. We need to be pushing in the direction of saying, we know which of you in the room are most likely to have a heart attack or a stroke. In fact, we could do it for all of the data in David's system. He and I and our teams could sit down with the algorithms that are available and have been peer reviewed and agree which of the patients that he has healthcare records on, or go to the CMS data, say which of the patients covered in CMS are most likely to have a heart attack or stroke, and then ask ourselves, are they getting all the therapy that might help prevent their next heart attack or stroke? And guess what we would find? We would find a dismal performance in terms of identifying them and getting them on the therapies that can help prevent the downstream consequences of a heart attack or a stroke. And so as a result, the country suffers about a $600 billion a year loss to GDP from events, again, most of which could be predicted. I wish as we go through the list of serious diseases that we would see improvement, but it doesn't get any better when you start transiting down the list from most frequently occurring to less frequently occurring. And something like osteoporosis is another clear example. It's very easy to predict, even inside a pretty narrow window of time, which women in particular are most at risk of having a fragility fracture, particularly after the age of 55. So those data are available. We can go into a health system and identify the women who probably should have their skeleton protected by one of the therapies that are available to meaningfully reduce the risk of those fractures. And yet that's the friction that's still difficult to break through in our system. And as a result, we have a lot of chronic diseases in the hospitals. We have a lot of acute events in the hospitals for things that if we were able to wave our magic wand over the population, we would be able to prevent with the innovation that's available today. For the innovation that doesn't yet exist, for neurodegenerative disease or for the very many cancers for which there are still challenges, we need to do more. And we need to protect the special ecosystem that exists in the United States for fostering innovation. That ecosystem does not exist all around the world. It has existed for some time in the US, but it's at risk. And so again, I think as a society, at some point we have to decide, do we want more innovation or not? And if we do want more innovation, we need to protect the elements of the ecosystem that are required in order for us to have innovation flourish in the biomedical field in this country. So it's at once exciting, but frustrating. Exciting, Esther, because the pace of change and the ability to innovate's never been better, but frustrating because there's still so much friction across each of the different market segments that prevent it being easy for patients, like all of us on the stage, by the way. None of us has any easier go of it, as you just heard David suggest, than any of you. And we spend a lot of time in the healthcare system, and yet for all of us, it's still difficult to get what we need. And that's, again, partly because we've created a healthcare system that introduces friction, which is another way of saying slows the rate of adoption of therapies to manage the cost in that way, as opposed to what might be a more enlightened approach, which would be to say, let's embrace the things that prevent chronic or big downstream problems. Let's prevent those things and encourage the early adoption of them instead.
Thank you so much, Bob, for that. I think what you talked about really painted a great picture of what happens with existing innovation, and then what are the incentives that are going to get us to that next tranche of new innovations that we're going to need to solve all of those disease conditions that we're still suffering ill effects from. I want to shift the conversation a bit and talk about where we are in terms of funding and financing. I'm going to come to each of you just to outline, how do we start to pay for these shifts? You know, Meena, you have commented before that when you're going through a payment rule, IPPS, which is an inpatient patient prospective payment system, that with your rules, it's the equivalent of a whole, GDPs for countries. So it's a massive amount of money that you're shifting and moving around, and yet you're trying to shift this overall healthcare system up more upstream, closer to value-based care. You've spoken publicly about Medicare's goal to reach a value-based care system by 2030, and that includes all components, fee-for-service and MA. And so what are the levers that you're using right now? Is it quality metrics, or is it the payment rules? How do we fund and finance the shift?
D, all of the above.
Okay.
So we are you mentioned quality metrics. We have created what's called a universal foundation, where we are aligning all of the quality metrics across our programs in CMS. As someone who was a healthcare provider and had a big spreadsheet with 8-point font of the 500 quality measures that we were being held accountable to, I think this is a way to help really galvanize momentum for changing care on the ground, to eliminate confusion, and to also help crystallize then where the gaps are. Because it's not just about colorectal cancer screening, mammogram screening, depression screening. It's also moving towards patient-reported outcomes, and how do we assess disparities and equity? So it enables us to think about that next step. So quality metrics, yes, we are absolutely, especially through this alignment, by engaging these quality metrics across all of our programs. That is a key component. On the payment side, as I mentioned, these more holistic care models where these quality metrics are paired with spending the Medicare dollar in a smarter way and changing the incentive from a volume-based, I do a service and I get a payment, to if I take better care of someone and keep them healthy and keep them out of the hospital, then I get a financial reward for that. And I think on the innovation side, that creates an environment where if there is an innovation that, as I think people on this panel have discussed, that keeps someone healthy, that meets someone where they are, that addresses access issues, that ultimately enables people to be successful in these models. And why is that important? Because it keeps the person healthier. I think also we have several avenues through the Medicare program to incorporate new innovations. We have new technology add-on payments in our inpatient prospective payment system. We are constantly evaluating. We have in our end-stage renal disease payment system also, all of these acronyms, but ways that we try to provide additional payments for new technologies that are coming out for, to eliminate access concerns with their adoption. The latest example being that we just proposed add-on payments for cell and gene therapies for sickle cell disease, right? This is revolutionary, addressing underserved populations, and this is curative, right? So how do we try to make sure that you are enabling access to these therapies? And I think the last area, we talked about quality, we talked about these payment models. I think the last area is another aspect of the Inflation Reduction Act or the new drug law, what we are doing in negotiation. We are in the midst of negotiating the first 10 drugs that were selected following the rules set out in the drug law. And when we put out our guidance for this Medicare drug price negotiation program, we got input from everyone, including organizations represented by people on this stage, right? From patient groups, from drug manufacturers, health plans, providers, thought leaders. And one common theme, actually, Bob had mentioned at the end, that people go into healthcare because they want to help people, right? And we want innovations for the cures and therapies that people need to keep our country healthy. And we want to enable access to those treatments. So what we put out in our guidance for the negotiation is that we are interested in hearing how these drugs are changing people's lives in the real world, in their communities. We held 10 patient-focused listening sessions so that we could hear directly from people who take these medications, from their caregivers, from their doctors and other healthcare practitioners, so that we can incorporate that as we're thinking about how do we help to support innovations that are addressing an unmet need, addressing the disparities that exist in our populations, really are making leaps and bounds in keeping people healthy. So I think that's another avenue where we are working to bring those innovations to bear.
Yeah, thank you so much for that, Meena. Bob, I want to bring you into this conversation and ask you maybe a different question around some of these topics, especially those that Meena laid out, which is we also need to think about funding and financing differently by working with different players, right? We've talked throughout the conference already around the role for non-traditional players in the space. How do you potentially take therapeutics directly to consumers? Just interested in your thoughts about what are the friction points from your perspective. You outlined a number that are the most challenging on the payment side, and if you could wave your magic wand that you would want for us to overcome as an ecosystem.
Well, I think the central problem is clear. We've created a system which is so complex that it's imploding under the weight of the complexity that we've created. And we're either going to wait for that implosion to occur, or we're going to have the courage to say we need to blow it up and figure out a better way to redo it. So let me give you an example or two. If you take the aggregate cost of billing information and records in the United States healthcare system, the aggregate cost is 18% of healthcare spend. And ask yourself, how much value is created by that 18% of healthcare spend? And when you're asking yourself that question, just reflect for a moment that the aggregate cost of all the medicines taken in the United States is 14%. So it's 4 percentage points less than the amount of economic activity that's devoted to billing information and records. That's insanity. So that's an example of the administrative complexity in our healthcare system. We believe that if you add up all the complexity and the cost of administering it, it's north of $800 billion a year. So the issue is not whether there's sufficient resources for us to have a healthier nation, a nation in which more people have access to the world's leading care. We have the resources, it's just misallocated. And it's misallocated for a series of reasons that relate to how our healthcare has evolved through decades of incremental legislation, policies, procedures, and it results in things like what we joke about on this stage and in rooms like this, the fact that faxes are still being sent around, the fact that we don't have access to digital. It's an incredible accomplishment, what David described, that some of this information is now digitally available. But listen to what he's saying. Listen to how long it's taken for that to happen. And that's why we're spending 18% of the United States resources in healthcare on billing information and records. So, if we were able to grapple with some of the fundamentals of the administrative complexity in the system, I think we'd have a lot more resource available to make sure that we continue to have innovation and that the citizens who need that innovation can get access to it. So, I would advocate for enough of of the Band-Aids being put on and pulled off. You know, we need to have the courage to look at this more fundamentally and tackle the interests at the state level and the federal level and all the vested interests that we have in the room here by trying to create a more sane digital connection for us as citizens with our healthcare data, with the result that the cost is more transparent and the processing is more automatic. If other segments of the economy, if the financial services economy were running anything like what we have in the healthcare economy, this would be a much less vibrant country than it is today. Fortunately, capital markets and other parts of the economy have long ago moved beyond what we're still stuck with in healthcare. And I think we have to just accept that a lot of the responsibility resides with the government. I'm not saying it's the government's fault, but we're all trying to comply with a variety of, again, state, federal rules and regulations that require us to continue to use antiquated systems. And we're missing one of the great opportunities available in the United States, which is the entrepreneurial ability to gather data, transact with data, make sense from data, and I think it's tragic.
David, do you want to react to that, just that missed opportunity, right? Because how do we overcome our inertia for change in healthcare? I agree with you, Bob, that is just the fundamental foundation of the American spirit. I've had the opportunity to travel around the world, and every single time I'm in a different country, they point to the ability of the United States to innovate and to be creative. So David, I'd love for you to react to that, because why are we still so far behind in the healthcare industry relative to, I can take my cell phone now and pay for my groceries by just tapping my phone at the checkout point, but I can't do that certainly with healthcare.
So I think my number was 1.5 trillion of your 800 million. I think it's actually worse than you're saying.
I'm happy to go with 1.5 trillion.
Yeah.
At least 800 million.
Yeah, so there's just amazing, and that's just the back office stuff, right? We think we can really help there. We really, really think that we can bring the same technology that we've done in other industries to that payment processing, claims, pre-authorization. And I think the AI is going to, and cloud and interoperability, and I think multiple administrations have been pushing interoperability. I think actually the legislation's going our way, and same with the regulations. The other place that there's huge waste is actually with the workforce, right? So I get this opportunity to go around. This month I'm in Sweden, Dubai, and Qatar. And wherever I go, they all start with the same thing. Oh, our healthcare system is different here than what you have in the US. Let me tell you what's wrong here. We can't afford the nursing cost. Like, it's the same list of problems wherever you go. And when you look at nurses are, and they're burnt out. And so in Australia, they're stealing nurses from New Zealand. It's like this game that's just going around. And if you look at the core business that we provide, we really provide in healthcare people. Like, that is the business. And the normal playbook that health system leaders used, I used all the time. If you had a bad year, you got rid of a couple social workers in the ER, you got rid of catering, and you beat up on the insurance company, and you lived to fight another day.
Anybody who couldn't bill.
Yeah, exactly. That game is not working anymore. It is fundamentally broken, right? So the cost of labor is so high, the cost of all the back office stuff is so high that you need a new playbook. And we think that a lot of the pressure relief can come from changing the workflow of your workforce. So if you really look at a nurse, and we do this, they spend 50% of the time at the terminal. They spend 30% of the time looking for supplies. They literally hide them in the tile in the OR because they don't know if they're going to have that tomorrow. And 20% of the time nursing. So I keep saying we don't have a nursing shortage. We have a nursing work allocation issue. That if we can get rid of that terminal time, even cut it in half, and we could get rid of the, where is the IV pump, we really have an opportunity to now keep nurses engaged in what they're doing. Back to Bob's point about people went into this for the right reason, and you can tell this story for anyone in the clinical workforce. Now you get to do what you wrote in your personal statement. The reason you went into this We think we can see a dramatic decrease in the cost for providers, for payers, for clinical discovery if we take all, we've turned the workforce into computer data entry people. And that doesn't happen in other places. It just doesn't happen in other industries. So that, I think, is a fundamental change that could have the ability to make it way more joyful to go back to work, keep people engaged. You know, most nurses now want a job where they work administratively and do or something because the nursing is so hard. They never complain that it's hard at the bedside, right? They complain about that other stuff. And so I think we can fix that, can have a dramatic decrease in cost. And I kind of think the system is right because the regular stuff isn't going to work right now.
Yeah. And Karen, we have heard from Meena, large payment rolls, you know, massive amount of money that's moved at the federal level in Medicare. We've talked about the workforce. We've talked about some of the administrative burden. But when we talk about financing, that happens in funding, especially in cancer care, it goes all the way down to families as well, right? You've done a lot of work. ACS has written a lot around financial toxicity. Why don't you just tell us a bit about what you're seeing at that patient level, family level? What are they facing with cancer care and the cost and financing of that?
Yeah, so financial toxicity is real. It's a real toxicity that impacts outcome. And what we are seeing across the country is that 42% of people in the US who get a cancer diagnosis deplete their life savings. So that's not sustainable. We're seeing incredible gains in our ability to treat cancer with therapies that are curative, words that we didn't use sometimes 10 years ago. But we've got to determine how to pay for it. And I think there's only one way that we will do that. We must shift to the left, again, to that prevention and early detection. And I'm going to take Dave's dream here, and I'm going to say yes and bring it a step forward. You got to get care to home. And by care, I mean prevention and early detection. So, you know, increasingly, we are working at the forefront of that innovation to think through. We have a whole series of grants called AHEAD grants that we fund, and it's all about implementing things like wearables, early detection, screening coming to home. Look at the revolution that stool-based screening has done for colorectal cancer so that we can truly identify more people who are at risk, who need to go on for a follow-on colonoscopy. Think about the impact of that kind of innovation on rural America, and that's just a parable. But in order for us to afford all of this innovation, we really do have to think about making sure that we're decanting from the clinics, the people who don't need to be there and who can be cared for from the home and thought about. So let's just take an example of where this could really be profound. Let's talk about prostate cancer. So prostate cancer is a highly survivable cancer. So upwards of 99% survival rates as someone is caught, back to what we talked about before, stage 1. Can be cured through radiation therapy or surgical intervention. But that's not what's happening. It's a second leading cause of cancer death for men in this country. So that's telling you already the story. You're not catching these cancers early enough. Well, prostate cancer screening is not like colonoscopy. It doesn't require 2 days off work. It doesn't require an actual intervention where you really do need to come to a clinic, because I don't think at-home colonoscopy is going to be a thing, just saying. But what is
Cologuard.
Cologuard, yeah. So, but that's an initial step. But on the prostate side, it's a $1 blood test. So you have to ask yourself, why is it that a $1 blood test is not being widely implemented for a cancer that's not only the second leading cause of cancer death for men, but for which we're also seeing a 5% year-over-year increase in men being diagnosed with more advanced disease that we cannot cure? We have a screening problem. 33% of men, all demographics in the United States, get screened for prostate cancer. It's abysmally low. So if we are going to be able to reduce financial toxicity on patients, improve lives, save lives for cancer, we have to take the things that are easy, the dollar blood test, go get it done. The things that are easy, we have a cancer vaccine that will prevent 6 different cancers. I don't know a parent alive who wants their child to face a higher risk of cancer. The HPV vaccine will end cervical cancer as we know it, 50% of head and neck cancers. But so few in the United States vaccinate both their boys and girls. We talked about this yesterday. Puerto Rico is going to be the first place in the US to see cervical cancer end because they have taken the trouble to understand the impact, and 90% of adolescent boys and girls are vaccinated against HPV in Puerto Rico. That's the power of advocacy and working with elected officials too. But the bottom line is we must continue to innovate, escalate innovations through working in partnership with for-profits that we can work with. We have a JV with Color Health to get cancer screening to home. We have an entire arm of ACS called Bright Edge, which is intended to escalate our ability to get those innovations which have already existed to people. And I'll leave you just with this last statistic. If all innovation ended today, if all innovation for cancer stopped, and we could just get people to the innovations that we've already taken the trouble to develop, we would reduce cancer mortality by 20%. Yeah. So it's something we really have to think about.
Yeah, absolutely. What a powerful number that we have to grapple with there, because in fact, that's a tragedy. Like, why are we not able to do that today?
The dollar PSA blood test.
What that's translating to, Karen, in real terms, are lives lost. People and families are feeling the effects of that because we're not talking about development of net new. We're talking about just implementing what we currently have. In our final remaining minutes, I just want you to go down. I will just go down the row here. What's your outlook for your sector, for your industry in the next 12 to 24 months? What's top of mind? Meena, let's start with you.
Okay. Outlook. Well, I think that we are going to continue to push to move care upstream, continue to keep access to care front of mind. One other thing that I did not mention, a big change coming to Medicare, is the $2,000 out-of-pocket cap for drug costs, to the point that you made, Karen, about the financial toxicity of care. Seniors who are right now spending $8,000, $9,000 a year on their prescription drugs, no more starting January 1st, 2025. And what that does, again, for access to the innovations that companies like, Amgen are providing. Continuing to push on supporting primary care, behavioral health, really the foundation of our system that can really help to keep people healthy, keep them in their homes. I think that's what we're looking at next 12, 24 months.
All right, thank you. Karen?
We're going to continue to push on innovation. We're the largest funder of cancer research outside the US government, so we do need to continue to push there, but also to lay the pathway for access to those innovations, sometimes through policy. The MSED Act, the Multi-Cancer Early Detection Act, is one of our major federal priorities to lay a pathway for reimbursement so that when this early detection type strategy beyond the screenings we can do right now go to home, that individuals across the country will have potential access to that. So those are some of our major priorities, in addition to continuing to spark the kind of innovation that's AI-enabled through imaging as well as workflow so that more patients get matched to the right therapy the first time.
Excellent. David?
So let me start with what we're not going to do. I think tech companies often come into healthcare and think those of us in healthcare are stupid, and they say just use this app and everything will get better. And there's this graveyard of that stuff. So we're doing it differently. We're not coming in with point solutions. We don't think point solutions make sense in healthcare because the ecosystem actually spits them out. So we're going for a full end-to-end. We're going to create the entire platform. And the other thing we're going to do is be incredibly humble. We're not doing this by ourselves. We want to be open and connected. We announced that we're increasing our APIs to our EHR by 300% publicly. We want people to build on top of what we're doing because we think the innovation comes from on top. We want to create that end-to-end platform in a very humble way.
Mm-hmm. Bob?
I think innovation will be the hallmark of what emerges from our industry over the next 12 to 24 months, and that's certainly how we feel at Amgen. So innovation any day now, hoping to have an innovation approved for small cell lung cancer, something that feels to us like a breakthrough that's been 30 years in the making. That's a disease for which there's been very little to help advance overall survival. We're hoping to change that imminently. Innovation in disorders like obesity. We hope to help rewrite the understanding of obesity and the diseases that are caused by it, and innovation in the area of autoimmune disorders as well. So I think we're in a period that's ripe with the opportunity to be able to tell patients who lived believing that there are no good therapies available for them, that has changed, that there are now therapies available, so we can join the fight to make sure that those patients then get access to that innovation and have the opportunity to live the long, healthy life that the innovation promises for them. So exciting time in the industry, and looking forward to being able to capitalize on changes in the digital environment in particular to try to break that remaining friction between the innovation and patient being able to get access to it.
Well, thank you so much to each and every single one of you. It's been a fantastic conversation. We started off this conversation talking about prevention, right? Prevention and innovation leading to healthier lives, and each of you have talked about that. All of you are change agents, you're champions for what the society needs differently. And the importance of that, what it translates down into are us closing those disparity gaps that we see, both on life expectancy, what we see across cities and populations, that we can benefit fully as a society from everything that we talked about this morning. And certainly prevention is top of mind for the work that we're doing here at the Milken Institute, and certainly welcome all of you to join us in that effort. So Meena, Karen, David, Bob, thank you so much for being with us this morning.